the voiceover PowerPoint for the neurological assessment and brain disorders PowerPoint. Our nervous system consists of the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which includes the cranial nerves, spinal nerves, and autonomic nervous system. The nervous and the endocrine systems of the body maintain homeostasis and the coordination of the body's functions. The neurological system works through electrical and chemical messages transmitted from sensory organs to the brain and spinal cord, and reciprocating messages transmitted back to target organs and cells. Dermatomes correlate to an area on the skin that is supplied by a specific spinal nerve and maps where the nerve fibers provides sensation or feeling. Our neuro assessment begins with a complete history. In addition, we're going to look at physical assessments. There are 3 major assessments that we use: the Glasgow Coma Scale, the Mini-Mental, and the cranial nerve assessment. So when we're looking at assessing a neuro patient, the best indicator of neurological deterioration is a change in level of consciousness. Assessing level of consciousness involves identifying patient responsiveness and orientation to person, place, and time. There are different categories that describe level of consciousness. So like confused, lethargic, stuporous, obtunded, or comatose. Level of consciousness can be assessed using the Glasgow Coma Scale. This is the priority assessment for any potential head injury. The GCS assigns a score for eye-opening, best motor response, and verbal response. The highest possible score is 15, with a score of 8 or less indicating severe neurological issues. Cognitive function, we're going to measure with the Mini-Mental Status Examination. It's a tool that is used to assess cognitive function. It's a tool that assesses the patient's orientation, attention, calculation, memory, and language abilities. Our cranial nerve assessment is a critical component of the nursing assessment of the patient. It can identify neurological impairment due to disease or trauma to the brain. In addition, we can use a variety of motor assessments. We're not really going to go into a lot of those, but your Romberg test, your Babinski test, those are not ones we're going to look at right now, but we have many different assessments for our neurofunction. The sensory system, we're assessing to determine if the patient can feel or identify specific sensations such as temperature, vibration, superficial or deep pain, position, and cortical sensory interpretation. This is particularly important when performing a spinal cord assessment. There are a variety of diagnostic tests that we can use to assess the functioning of our neurological system, like a CT. CTs take that cross-sectional image and is viewed as cuts or slices that allow the provider to view the brain, spine, and orbits in a quick, non-invasive manner. It is used to assess for bleeding, edema, or masses. We also have the PET scan. It involves the administration of radioactive glucose. It is used to detect areas of increased metabolic activity in the body. We have the MRIs. These are non-invasive and painless imaging studies that use magnetic fields to obtain images. It is something that we use for clear visualization and detail of very small structures. There is an MRA, which is a type of MRI that uses the radio wave signal characteristics of flowing blood to get images of the body's blood vessels. We are using this to determine the presence of any aneurysms, clots, dissections, or vessel stenosis. It's performed in the same way as an MRI, with the same patient preparation and nursing implications. So when we're looking at the MRIs and the MRAs, Remember, we're going into a giant tube. It's very loud. It causes people a lot of anxiety because it's very small and claustrophobic. So, people need to be prepared for this, and they may need some Ativan or some sort of sedative when they're taking this test. Plus, they need to have nothing in their pockets, no metal. That can definitely screw some things up. So there's a lot of nursing interventions that are with these two tests. So we also have the cerebral angiography. This is an invasive intra-arterial radiological procedure that involves the administration of the radiopaque dye through a catheter inserted in an artery, typically the femoral artery. Evoked potentials, I don't think we're going to go really into that. CTAs, lumbar puncture, I think is very important to discuss. This is one that you will help a lot with the physicians. It is basically taking a needle, putting it into your spine, and then having the fluid, the spinal fluid, removed and examined. They're going to look at it and see if it's clear, if it's cloudy, does it have bacterial infection, is it viruses, fungal, all sorts of stuff they're going to take a look at. That's a very common procedure. They usually do it at the bedside, so the person is either lying on their side or they're bent over kind of in a tripod position, opening that spine up so that the neurologist can go in and do the lumbar puncture. Myelography they can do, biopsies, all of these are very common, and you will see them using these to try and figure out your patient's illness. So we're going to look at a few brain disorders. This list is not exclusive. There's so many brain disorders. We just really don't have the time to cover all of them. But these are some very common ones that you will see. Seizures, meningitis or encephalitis, Parkinson's, and Alzheimer's. And we'll spend some time on each of these diseases. So the clinical manifestations of seizures. The classic clinical presentation, it's related to the classification, and it can range from rhythmic jerking of all extremities and loss of consciousness as observed in generalized tonic-clonic seizures to episodes of apparent daydreaming and no loss of consciousness as observed in absent seizures. Partial seizures are typically more localized and may have a loss of consciousness, but this does not occur in all partial seizures. Other clinical manifestations include unilateral, rhythmic muscle movements, automizations, which is the repetitive unconscious movements such as lip smacking, chewing, or swallowing, sudden loss of motor tone, and incontinence. So depending on the type of seizure the person is having, and the risk factors associated with those, that will determine our seizure precautions. The diagnosis of seizures is made via imaging like CT or MRI, and laboratory workup is going to be used to rule out any other causes like lesions, tumors, metabolic disorders, etc. And through these diagnostics via EEG monitoring for abnormal electrical activity, we should be able to get a diagnosis. In some instances, sleep-deprived EEG may be performed. Stress, such as that's found when the individual is deprived of sleep, causes an increase in cortical activity and is a key trigger for seizures. Interviews with the patient also establish any commonalities of the activity, like auras or posectal symptoms. So medication, it's very important. This is a major approach. This is how we medically manage these seizures disorders. Anti-epileptic drugs or anticonvulsants almost always provide complete control of the seizures. Generally, one medication is prescribed to achieve optimal control. Combination of medications may be required and are introduced one at a time, with the patient observed for breakthrough seizure activity until the new medication has time to reach the therapeutic effectiveness. Complications, seizures lasting longer than 5 minutes. It's a medical emergency. Seizures lasting longer than 30 minutes can cause respiratory failure, brain damage, and death. Status epilepticus, seizure activity which is lasting longer than 5 minutes, or 2 or more seizures without full recovery of consciousness, can be caused by head trauma, hydrocephalus, acute drug or alcohol withdrawal, metabolic disturbances, or abrupt withdrawal of the anticonvulsive medications. Airway, breathing, circulation interventions must be initiated immediately. Nursing management, we're going to look at the nursing diagnoses, looking at that ineffective breathing pattern, risk for injury, ineffective coping. There's different types of seizures. You should have probably covered this in pathology. Reacquaint yourself with all these different types because we're going to see a variety of manifestations. So the clinical manifestations of seizure vary widely depending on the etiology of the disorder and the area of the brain involved. Management of seizure activity requires careful observation. Clinical manifestations include tonic movements, clonic movement, loss of consciousness, aura, automaticisms, loss of motor tone. All of these are things we're going to see. What we need to be very concerned about is our airway. During the seizure in the postictal state, the patient may have a compromised airway secondary to decreased level of consciousness. We need to monitor vital signs like the blood pressure, heart rate, oxygen saturation. Monitor these during and after the seizure. Elevations in heart rate and blood pressure may develop during the seizure. Respiratory changes, including the airway compromise, may develop after the seizure. So seizure activity, we want an accurate diagnosis and treatment of the seizure activity. These are facilitated by a detailed description of patient observations immediately before, during, and after the seizure. We want to look and assess for a presence of an aura. Some patients may experience an aura in advance of a seizure, allowing the patient to assume a safe position. So our actions and interventions, we want to set up suction equipment at the patient's bedside. The patient may be unable to protect their airway after the seizure and may require suctioning of the oral airway. We want to have oxygen available at the patient bedside. During the post-ictal phase, the patient may require supplemental oxygen to maintain the oxygenation saturation within normal limits for the patient. Safety measures. We want to look at having the bed in the lowest position, suction at bedside, oral airway at the bedside. For the patient experiencing a witnessed seizure, protection includes not forcing any object into their mouth because sometimes people fear they're biting their tongue off, they're going to break teeth, they're going to cause injury. Don't put anything in their mouth. We want to loosen any restrictive clothing, turn the patient to the side, preferably to the left side to reduce the risk of aspiration. We should not be attempting to restrain the patient's movement. However, guiding the movement may be necessary to prevent injury. If they're smacking their head or arms onto a wall, maybe we pull them away from the wall, but we're not pinning them down to the ground to keep them from moving at all. We're guiding them away from injury that we see. We may need to place an IV catheter. IV access may be needed to administer medications to stop the seizure activity. We want to document the specifics of the seizure, providing, date, time, duration, a clear description of the seizure, the sequence of the seizure progression, the pre-ictal and post-ictal observations. All of that's important to know. Teaching, definitely make sure our patients understand their medication regimen. Control of those seizures it's largely determined by the therapeutic levels of prescribed anti-seizure medications. So they have to know, like, hey, if they've not had a seizure in a month and so they've decided to stop taking their seizure meds, they're probably going to have another seizure. And the reason it's well controlled is because they have been so compliant with their medications. We also may want to advise them to have a medical alert bracelet in case of a seizure activity. It helps us understand what it is because, as a stranger, as a nurse practitioner, I can come onto a person and they're down on the ground and I don't know if they're having a heart attack. I don't know if they're in a diabetic coma. I don't know if they've had a seizure. I don't know, but a medical alert bracelet will give me a clue of kind of what I'm looking at here. Not exclusively, but it does help, direct care a little better. Driving restrictions. A lot of patients with seizures are not going to be able to drive. So it's very important to follow the rules of your state and to make sure that they understand that, it's a safety issue for all involved, but obviously follow the laws of your state. Meningitis is classified as acute or chronic. Acute meningitis indicates a bacterial cause with the presence of clinical manifestations occurring in hours to days, and CSF pleocytosis, which is a markedly increased white blood cells. The inflammatory process within the meninges leads to increased turbidity of the CSF, leading to sluggish flow of the CSF. Acute bacterial meningitis is a medical emergency. Chronic meningitis has an onset of symptoms during it's like weeks to months, with a duration of symptoms longer than 4 weeks. Risk factors. So we have to kind of look at the incidence of meningitis. It's typically seen in settings where people live in close proximity, including college dormitories, military barracks, and prisons. Meningitis can also be caused by other factors such as pericarditis and myocarditis. Therefore, assessment of additional data such as heart murmurs and results of an echocardiogram are analyzed to rule out these causes. Other causes of meningitis include infection from a cochlear implant, conjunctivitis, and exposure to animal bites. All of this requires further investigation. So your clinical manifestations could be a change in level of consciousness, headache, fever, photophobia, nausea and vomiting, rhinorrhea, nuchal rigidity, the Brudzinski sign, which is that involuntary flexion of the hips in response to passive flexion of the neck with the patient in a supine position, or Koenig's sign. So I always like to think of the Koenig sign, use that K in Koenig is like the knee, K and knee. So pain in the back and leg and resistance to movement when the leg is flexed at the hip and then straightened at the knee. Clinical presentation of meningeal irritation includes nuchal rigidity, which is that neck stiffness, and opisthotonus, which is severe hyperextension of the head with arching of the back. In severe cases of meningococcal meningitis, a faint petechial rash can develop, which develops into disseminated intravascular coagulation, DIC. It's very important that you know the clinical manifestations and the difference between subjective and objective findings. So our diagnosis, we're going to look at and examine the CSF via lumbar puncture. This is the hallmark for diagnosis with meningitis. Patients that are, we have suspicion for space-occupying lesions and new onset seizures. For those that have a moderate to severe altered level of consciousness, they require a CT of the head before the procedure because they're at a higher risk for herniation. Medications, we're going to look at the initial assessment, the presumptive diagnosis, and before the confirmation of the microbiological data, we're going to start broad spectrum antibiotics. Treatment for meningitis is dependent on the penetration of the blood-brain barrier by the chosen antibiotic as well as by the type of pathogen itself. Treatment for meningitis generally requires 14 to 21 days of antibiotic treatment. Long-term IV access, such as peripherally inserted central lines, PICC, or other central venous access is typically initiated because of the need for long-term antibiotic therapy. Complications, we're looking at increased intracranial pressure. It's a life-threatening complication of meningitis, and identification and treatment of this increased intracranial pressure is vital. Early signs of increased ICP are identified during neurological examination requiring frequent assessment. The use of dexamethasone to reduce inflammation in the treatment of meningitis remains controversial. Several studies have shown a reduction in hearing loss And those patients with meningitis caused by H. influenzae, which is like the flu bacteria here, or a flu bacteria, irritation of the cerebral cortex can cause seizure activity in the patient with meningitis. Patients with meningitis are also at risk for syndrome of inappropriate antidiuretic hormone, or the SIADH, and diabetes insipidus. So the neurological examination is the most significant nursing intervention in the care of the patient with meningitis. Neurological status. So because the risk of intracranial pressure, increasing intracranial pressure, secondary to increased turbidity of the CSF, frequent neurological assessments are essential to recognize subtle signs. Changes in level of consciousness are the earliest sign of increased intracranial pressure and should be reported immediately to the healthcare provider. Sign of meningeal irritation, like nuchal rigidity, Brodzinski sign, and Koenig sign. The inflammatory process in the meninges is causing pain upon movement of the neck, and the patient guards the neck. In the patient with a positive Brodzinski sign, there's an involuntary flexion of the hips in response to passiflexion of the neck in the patient in the supine position. Ensure there's no cervical spine injury prior to attempting. To assess Koenig sign, the nurse starts with the patient's hip and knee flexed at 90 degrees, and then slowly extends, don't force the knee. Pain behind the knee and repeated pain bilaterally are indicative of a positive sign. We're also going to look at vital signs. An elevated temperature develops secondary to the infection process. If intracranial pressure is increasing, the blood pressure increases with a widening pulse pressure and decrease in the heart rate. We're going to also want to monitor blood pressure for signs of hypo or hypertension and heart rate. If the patient develops SIADH, fluid is retained and there may be an increase in blood pressure. With diabetes insipidus, the patient has increased output of dilute urine and is at risk for hypovolemia, hypotension, and tachycardia. Headache. The inflammation of the meninges may lead to headache. We're also going to want to look at a cranial nerve assessment. Particularly, we want to look at 3, 4, and 6. The eyes on the affected side can deviate down and out because of the dilated light-fixed pupil. We're going to look at the CSF results. Treatment of meningitis, particularly bacterial infections, is directed to the specific organism that is isolated in the CSF sample. We're going to look at daily weight because, again, if we're losing a huge amount of fluid, we're going to have some issues with the body weight. Renal function, so many antibiotics are cleared by the kidneys, so increased in the bun, increases in the creatinine may demonstrate damage to the renal system. And we're also going to do vascular assessments. In the patient that develops disseminated idiopathic coagulation, there may be increased bleeding as well as it is in decreased peripheral perfusion. We're going to start with some actions. Our nursing management, which includes the actions and interventions. So administer IV fluids. The patient may have a change in fluid volume status. We're going to administer antibiotics as ordered. If they require therapeutic dosing, we have to monitor those judiciously to facilitate their therapeutic goals. We're going to decrease environmental stimuli, dim the lights, provide a quiet environment, having a sensitivity towards, lights and sounds, very common with meningitis. Maintain the head of the bed to 30 degrees to reduce that intracranial pressure. We're going to manage pain. We're going to implement those transmission precautions. So standard precautions are maintained for all patients, include droplet precautions. Obviously follow what your hospital policy is. We want to maintain their temperature because they could have a really high temperature. So we're going to look at the antipyretics, cooling baths, cooling blankets. We're going to teach. It's very important to follow up with your appointments. Recovering from meningitis can take weeks to months. We need a lot of assessment and evaluation by the healthcare provider. We want to stress the importance of taking their full course of antibiotics. And it's definitely, long. So they're going to have to be reminded that even if they feel better, they need to take their antibiotics. We're going to look at and evaluate the care. So the management of meningitis requires eradication of that infectious organism. During the acute phase, the patient's chief complaints are pain, neck stiffness, and photophobia. Definitive interventions focus on antibiotic therapies and comfort measures. Antipyretics may be used with fever. We want to monitor for increased intracranial pressure, especially during that acute phase. Upon discharge, the patient will be neurologically and hemodynamically stable, and the patient needs to be knowledgeable of the signs of recurrent infection and increased intracranial pressure to seek emergent treatment. So if we send you home, you think you're getting better, then you're not getting better, we need to see you again. Compliance with antibiotic therapy after discharge is also a priority because a patient may be discharged while still receiving antibiotic therapy. So encephalitis is that inflammation of the cerebral cortex and white matter. It involves both the brain and spinal cord. When it does, it is called encephalomyelitis. Risk factors for the encephalitis is primarily caused by enterovirus such as herpes simplex 1 and 2, arboviruses such as rabies, Lyme disease, West Nile virus, all that stuff. We have clinical manifestations. They present with encephalitis, including or the encephalitis is associated with this kind of infection process, fever, neurological defects, deficits associated with damage to the brain and spinal cord. So we need to look at that change in level of consciousness, fever, headache, photophobia, phonophobia. Phonophobia is that whole, sound sensitivity, weakness, nuchal rigidity. So while the infection process develops, clinical manifestation of increased cranial pressure may be present, including a change in the level of consciousness. So we may see lethargy and disorientation, as well as focal signs such as muscle spasms and paresthesias. The diagnosis of encephalitis follows these procedures and protocols of meningitis involving an examination of the blood and CSF, as well as EEG, CT, and MRI scans. So nursing management of encephalitis, we're going to do assessment. So look at the neurological functions. Infectious process in the CNS may act as a space-occupying lesion and increase intracranial pressure, leading to changes in the level of consciousness. We're going to look at the vital signs because this is an infectious process. The patient may have elevated temperature and tachycardia. If ICP develops, an increase in blood pressure and widening of the pulse pressure may develop. Nuchal rigidity, Brzezinski's and Kernick signs, signs of meningeal irritation and involvement in the brain itself can lead to an extension, so that infection is going from the brain into those meningeal layers. Cranial nerve assessment, particularly we're going to look at 3, 4, and 6. The eye on the affected side can deviate down and out. We're going to look at intake and output. Fever may increase insensible water loss. Some of the antibiotics and antiviral medications, it can cause nausea and vomiting and diarrhea. We want a complete blood count. Antiviral medications can cause hematological dyscrasias, granulocytopenia, neutropenia, anemia, thrombocytopenia. We're going to monitor liver function tests because the antivirals and antibiotics may lead to an elevation in liver enzymes due to potential hepatotoxicity. So our nursing actions, we're going to position the patient with a head of bed elevated to 30 to 45 degrees with the head in good alignment. This position facilitates venous drainage and minimizes the risk of increased intracranial pressure. Implement seizure precautions. because the potential for increased ICP, as well as the presence of infectious process in the CNS, the patient's seizure threshold is decreased. Encourage oral intake is tolerated. Because of nausea and vomiting that may occur as a side effect of medications, it's important to optimize dietary intake. We want to dim the lights, have a quiet environment. These interventions decrease environmental stimuli. Bright lights and loud noises may exacerbate headache. Patients may have photophobia and phonophobia. So turn and reposition the patient every couple hours. Because of limited activity, they could have complications of immobility, particularly like skin breakdown. Administer stool softeners to prevent constipation. We want to, because of, limited activity, because of nausea, vomiting, decreased oral intake, we just have that increased risk for constipation. Minimize that Valsalva because of that potential to increase intracranial pressure. So we don't want to be really straining to go to the bathroom because that will increase that pressure. So teaching, we want that, look at that complications of immobility. So, we're at a risk for skin breakdown, deep vein thrombosis, deconditioning. The recovery process may be extended, and patients being compliant really does help minimize these side effects. We want to make sure they're going to their follow-up appointments because it's going to really take some frequent evaluations. Make sure they take all their antibiotics. So our management and our evaluation of care, we want to get rid of this infectious organism. Encephalitis, if you have an infection in your brain, it is extremely severe. So this is a patient that's in the ICU. It's really kind of dependent, how they recover is very dependent on how well we can manage that intracranial pressure. And how much injury has occurred because of that pressure. The nurse needs to work with the family and patients to ensure compliance with all prescribed interventions. And if they're not doing very well, we need to send them back to the hospital. Obviously, we can't, survive very long with a damaged brain. So it's important that they understand what our side effects are and what we're looking for. And if the patient's declining, we need to have them back. Parkinson's is one you're going to see frequently. It is a motor system disorder. It involves the loss of dopamine-producing brain cells in the substantia nigra of the basal ganglia, culminating in a decreased amount of dopamine in the brain. So this basal ganglia of the brain consists of several brain structures or collections of neurons. The striatum, the globus pallidus, and the substantia nigra. All of these are innervated by the dopaminergic system. Motor activity is the result of this release of the dopamine and the acetylcholine and the integration of the basal ganglia, the cerebral cortex, and the cerebellum. So typically our risk factors, exposure to toxins, genetics, age, our clinical manifestations. Parkinson's, we have things like resting tremors, muscle rigidity, slow movements called bradykinesia, or a loss of movement called akinesia, and postural instability. So we might also see issues with mood, cognitive issues, behavioral altercations. Typically we see weakness, fatigue, a mask-like face, shuffling gait, uncoordinated movements, and a widening gait. So the diagnosis is made when 2 or more of the cardinal symptoms with asymmetrical presentation, bradykinesia, resting tremor, rigidity, or postural instability are observed in the absence of other causes. So there's no specific diagnostic studies to confirm Parkinson's. So the presence of progressive decline and motor function, accompanied by the tremors and rigidity, is typically how a diagnosis is made. So medications will be initiated when symptoms become difficult or disabling for the patient. Anticholinergics, which can reduce tremors and drooling, may be used in younger patients. These medications typically aren't used in older adults because of the side effects, including confusion, memory impairment, blurred vision, dry mouth, constipation, and urinary retention. We can also use these dopamine receptor agonists, Requip. These are first-line treatments. Requip, Maripex. So side effects of these medications can include nausea, vomiting, urinary frequency, drowsiness, orthostatic hypotension, lower extremity edema, sleep attacks, disorders of impulse control. Surgical management, stereostatic pallidotomy for the control of the clinical manifestations associated with these involves opening part of the little brain up and inserting a device in there. This will be with multiple CTs and a stereostatic head ring. They can do, with a burr hole. We'll see this person in the neuro ICU, and then hopefully it'll reduce your symptoms. Here are some stages of the Parkinson's progression. We are looking at our treatments. It does typically affect men a little more. It involves toxin exposure, genetics, and age. There's rigidity, bradykinesia, this coordination of excitatory messages from the production of the acetylcholine in the basal ganglia, and the inhibitory messages from the dopamine via transport from the substantia nigra to the basal ganglia allow for the control of a steady, well-coordinated fine movement. A lack of balance between these leads to tremors, rigidity, and bradykinesia. So that's why we see those symptoms of Parkinson's. We're concerned about our gag and our reflex. May have difficulty swallowing, meaning we now have excessive drooling. We are at higher risk for aspiration because of ineffective swallowing. We have issues with mobility, ataxia, bradykinesia, postural instability. It does really decrease the physical mobility and the ability to complete activities of daily living. We also have to look at the bowel and bladder functions. Makes our patients at a higher risk for incontinence and constipation. Our nursing management is very important. We want to make sure we're giving them their medications to treat the clinical manifestations. We want to implement safety precautions. The etiology of these disease processes can affect sleep, driving while impaired, meaning your muscles aren't working, your brain isn't working well. You can have a little bit of dementia because of the Parkinson's. So we want to be careful with that. Evaluate, all that good stuff. We want to make sure that they are eating well, that we have the head of the bed elevated, we have suction equipment available, stool softeners, increase that fluid intake. We want to facilitate collaboration, communication, maybe get involved with a social worker. We want to make sure that they understand teaching, medication compliance, the effectiveness of these medications prescribed. It's really dependent on compliance with, dosing intervals. Patients should contact the provider if the effectiveness of the medication seems to be declining, because we can, do a dosage adjustment. We want some safety precautions in place, psychosocial support. And we want to evaluate care. It's progressive. This is a neuromuscular disorder that ultimately results in the loss of motor control and dependence on others for our ADLs. So it's going to be very important the patient, the family, all of these folks are involved. We have a lot more likeliness for them to fall. Patient safety is very important. We have weakness, we have instability, problems with swallowing. We will need to modify the living environment so that we can ensure patient safety, and maximize independence for as long as possible. It is estimated that 5.7 million Americans have Alzheimer's disease, 5.5 million older than 65, and approximately 200,000 younger than 65. It is also estimated that 500,000 Americans younger than 65 have some form of dementia, 40% of them with Alzheimer's. Approximately 2/3 of Americans with Alzheimer's disease are women, and there's an increased incidence in older African American adults. So our risk factors are going to be those that have blood relatives with dementia. They seem to be at a higher risk. Long-standing hypertension, brain injury, these are all proven to cause Alzheimer's disease. Our clinical manifestations: forgetfulness that progresses with time, short-term memory decline, cognitive impairment, an inability to handle personal finances, inability to self-manage medications, motor and verbal skill decline. Although many people develop periods of forgetfulness, there is initially little to no decline in the ability to take care of themselves. Forgetfulness is the first symptom of Alzheimer's, which slowly progresses to difficulty with language, meaning like vocabulary and fluency. Problems with short-term memory, such as recent events and conversations. Agnosia, which is the inability to process sensory information. Emotional lability, personality changes, and the loss of cognitive skills like abstract thinking, judgment, and calculations. These are all things that occur as Alzheimer's progresses. So there is also an inability to perform multiple or complex tasks, difficulty with problem solving. Later stages, the disease progresses to word-finding difficulty, difficulty naming familiar objects, items that are misplaced in the person. They can be very easily lost. The affect becomes flat, with a loss in social skills and change in personality. It can lead to aggressive, uncontrollable acting out and behavior. The ability to care for oneself can be so limited that the person is bedridden. Death can ensue as the result of infection, pneumonia, falls, malnutrition, and dehydration, often with multi-system organ failure. So diagnosis, officially it can only be diagnosed upon the examination of the brain following death. Neurofibrillary tangles and beta amyloid plaques can be observed microscopically. Presumptive diagnosis is made on the basis of a thorough history and physical examination that includes careful recording of clinical manifestations, as well as monitoring the onset, progression, and duration. Treatment. There's no cure for Alzheimer's. There are several medications approved, and it can maybe slow down what's going on. The acetylcholinesterase and butyrcholinesterase, which normally breaks down the acetylcholine and butyrcholine respectively. It increases communication between remaining neurons. It's also believed that vitamin E, an antioxidant, helps by decreasing the damage caused by free radicals, and is often used in combination with other medications. But do understand that a lot of these medications that they use will last, 6 months or a year. But after that, they kind of lose effectiveness. So it will help for a while. It'll slow things down for a while. But this is a progressive neurological brain failure. So today we will also look at in class this progression of the disease and what it looks like. Our nursing management is going to involve things like assessments. It's going to involve weight, intake, output measurements. We're going to want to know how much they're eating and drinking, bowel and bladder functions. What does their skin look like? Their activities of daily living, their environment, and their safety and coping. When we look at things like Alzheimer's, these folks forget. It's not just forgetfulness. What it is not, I guess the best example is people, go, hey, where did I leave my keys? It's not losing your keys and wondering where they're at. It's looking at your keys and not knowing what they are. So Alzheimer's is losing that ability to understand things around you. So you're not going to eat, you're not going to drink, you're not going to take care of your activities of daily living, you're not going to pay your bills. Some of these folks are very good with routine. They may have some confusion, but as long as they have routine, they can function. Other folks are going to be very confused, maybe not dress themselves, they may wander. They may be people that, they're dirty, they haven't been able to bathe themselves, or they forget to bathe themselves. This is where our nursing management comes in. So we have to, encourage them to do things. You may have to spoon feed them. You may have to try to really convince them to get a bath. Sometimes they can be very aggressive. And they can be very scared. A lot of times when you're seeing angry patients, they're just scared. So our nursing management is trying to do the best we can for these folks. I've taken care of many Alzheimer's patients, and you just do the best you can. Some days you're going to be able to get them to take a bath. Other days they're going to strike out at you if you do so. Do the best you can. Some days they will eat for you, other days they will not. And eventually they will not eat, or they forget how to swallow their food. They pocket their food, they pocket their meds, they don't take it. And that's when we give them, what they do like. If they like ice cream or they like yogurt, we just want them to get to eat something, just to get some calories in them. But eventually, these folks lose a lot of weight, they're not eating. When they're not swallowing well, they're also, at a very high risk of aspirating, and most of them die either of pneumonia or severe malnutrition, because this is not something they can eat, regularly. Again, we can talk about things like, feeding tubes and, IVs, but a lot of times they'll just pull them out. It's not really worth it to do those things, and that's when you have to have a discussion with the family and hopefully involve hospice in these conversations. So nursing management, we're going to assist with feeding, we're going to implement safety measures. This is often why patients are in locked units, because they tend to wander. We want them to be reoriented. They may be confused, or they know the wrong day or time, and this is not really the time that we want to argue with our patients. I think in general it's probably not a great idea to argue with your patients. You're not going to get a lot of compliance that way, but redirecting them when necessary, feeding them, we're going to have to look at toileting practices, put a clock or a calendar in the room to reorient them, get them walking, helping them with ADLs. We want to speak calmly and use positive statements and reassure them if they're agitated. We want to provide diversionary activities, provide the caregiver and the family with an emotional support system. This is very, very difficult. So it's certainly difficult and scary for the person that has Alzheimer's, but it is so hard for those people that are left behind and taken care of. Family members that were never aggressive that are now aggressive, that were never hateful and mad and angry, and now they are hateful and mad and angry. And it's such a huge change to see your loved one deteriorate in that way. So, we want to teach them how to care for the patient that has Alzheimer's. We want to teach them, how to look at dangerous substances, how to get a monitoring system, have the whole family involved. Often so many times when we have a sick relative, it always falls to one family member, and that poor family member is so stressed out and hurting so much because they're so burnt out. So we need referrals to support groups and alternative care settings if we have to. Depression is common. You know, we definitely need to look at assistance and medications. We want to make sure activities are happening during the day, less napping, because our days are kind of screwed up when we have Alzheimer's. And so that person, they may wake up at 1 o'clock in the morning, and then they're off like, hey, I got to fix the car. And you're like, it's 1 in the morning. And they're like, no, it's not, you know. And the poor family member is just so exhausted because the person is up and getting into things and they're worried. So definitely get some support. You know, this diagnosis of Alzheimer's is just frightening and very stressful for the patient and family. We want patient safety and quality of life. You know, these are very important with any progressive neurological disorder, and our priorities are that coordination and management of the care. So not only physical issues, there's legal issues related to patients. As their cognitive function declines, we have to kind of look at end-of-life decisions. We have to look at how our finances being held. We have to look at very complicated issues of, you know, who's making decisions. They cannot make decisions. They can't sign for themselves. They can't bank for themselves. So we have to really evaluate and look if, you know, get the family involved in what they would like to do and how they would best like to do it. And it can be very complicated and very overwhelming.